Okay. All right. Well, good morning, good afternoon, good evening, wherever in the world you may be. Thank you so much for joining us for Complex Lower Extremity Trauma 2025, presented by Harvard Global Orthopedics and Sona Global, in partnership with some wonderful organizations who have contributed to the faculty, not only in terms of resources, time, energy, and also faculty. Thank you so much. Next slide, please, Emily. So today, our topic of conversation will be neglected hip fractures and dislocations. Please look out for our future sessions coming up every Saturday for the next 4 weeks. Just as a reminder, we're using Zoom today. Everybody's quite familiar with this. Please keep your microphone muted if you don't mind, just not to disrupt the conversation. And we do have translated captions available if English is not your first language and you prefer to have captions in your native language. Just follow these instructions. If you click on the Show Captions button at the bottom and then click on the translation, it should allow you to have translated captions. So today, our course objectives are first and foremost, improve participants' foster international dialogue and discussion, and provide practical advice to surgeons who are practicing in resource-limited settings. And then third, motivate the next generation of younger surgeons practicing globally. So my name is Kieran Agarwal-Harding. I'm the director of the Harvard Global Orthopedics Collaborative. I'm the course chair for this program. And it's my pleasure to introduce Dr. Shravya Challa and Dr. Haley Daniel, who will be assisting with course moderation, helping answer questions and work with the faculty to work them into the conversation today. And I have to, of course, thank the incredible Sona Global and HGOC organizing team. So many members of this team who have been so instrumental to the organization of this course. This would not be possible without these incredible, extraordinary individuals who put in so much time and energy to make this happen today. And I encourage all of you who are on the line to check out Sona Global Academy and our online curriculum, which these wonderful people have been involved in helping create for all of you today. So it's my pleasure now to introduce our case presenters. So we'll start off with a presentation from Ethiopia by Dr. Getahun. Then we'll go to Malawi to Dr. Glory, and then to Egypt by a presentation by Dr. Mahmoud. And then we'll move to Sudan for a presentation by Dr. Mohammed, and then back to Ethiopia for a presentation by Dr. Biniyam. Thank you all for your contributions to this course. We really, really appreciate it. And now, of course, it's important for me to highlight the wonderful commitment of our case discussants. We've got Dr. Dwayne Anderson and Dr. Sammy Hailu, Dr. Isaac, Dr. Mai, Dr. K-Rod or Ken Rodriguez, Dr. Vishnu, Dr. Fassi, Dr. Sushant, Dr. Mike Weaver, Dr. Jack Wickstead, Dr. Philip, Dr. Pierre-Marie, and Dr. Paul Appleton. So today's agenda, this very quick introduction, which hopefully will be over soon, and then we'll jump straight into our case presentation, starting with Dr. Getahun. So without further ado, please, Dr. Getahun, if you don't mind, share your slides and let's go ahead and get started. Thank you all.
Okay. Thank you very much for the opportunity, Dr. Kiran and the Harvard Global Orthopedic Collaborative. So I'm Getahun, an orthopedic trauma fellow from Ethiopia. So today I'm presenting a case of neglected posterior acetabular fracture dislocation, operated 8 years ago by my mentor, Dr. Samuel Hailu. So the case at that time was 31 years old. He presented 6 months after sustaining rotothoracic injury. And as you can see, the X-ray has got left hip fracture dislocation with malinated posterior superior posterior wall piece and pseudoacetabulum formation, and obviously adducted and internal rotated femur. So has got neglected hip fracture dislocation. So for this particular patient, salvaging the hip joint was preferred because we didn't have arthroplasty service at that time, and he's a young man, and we want to preserve the hip joint for someone more years to come. So for this particular patient, we used modified Gibson's approach in lateral position. So step digastric trochanteric osteotomy was done. Following the osteotomy, tenotomy of the short external rotators was done 1.5 centimeter away from their insertion, and subsequently capsulotomy of the femur neck was done anteriorly. So since the capsule was adhered, the femur neck part of the capsule was dissected out anteriorly, and subsequently the malignant site was identified, and the posterior fragment was osteotomized, and fracture base was prepared. And after all the pericapsular, periacetabular capsule and fibrous tissue was released, then the fibrous tissue from the acetabulum up to the extent of transverse acetabular ligament was done. And the head was circumferentially identified, and drilling was made, and there was bleeding from the femur head. And reduction was attempted and was successful, and the head was kept in abduction and intraction position. So in that particular position, the posterior fragment was put in place to the fracture bed, and 2 lag screws were applied to keep it in position, and subsequently 7-hole recon plate was applied over the posterior fragment. Finally, the osteotomy site of the trochanter was fixed with 2 screws in lag mode. So this is how the trochanteric step-up osteotomy was done. Digastric, superiorly the VDS, and laterally have got vastus lateralis. So this is a step cut, 3 fuse and 2 fuse. And this is how it looks like anteriorly. Just we do step cut osteotomy, 3 fuse, 2 fuse junction, and it has to end at the vastus ridge site. For this particular patient, the short external rotators were tenotomized to access the posterior fragment as well. And this is how it looks like anteriorly after the trochanteric osteotomy was mobilized anteriorly and retracted. This is how the Z capsulotomy is done. And part of the anterior capsule from the neck was excised because it was extremely scarred and adhered. And the whole point of doing this osteotomy is for ease of access and for preservation of the blood supply to the femur head. So this is the medial circumflex femoral artery diving up, and this is the lateral epiphyseal artery coming in and going to the femur head cartilage bone junction few millimeters away from that area. And the tenotomy has to be done up at least 1.5 centimeter away from the insertion to preserve the blood supply. And this is how it looks like after the osteotomy. So this is cadaveric specimen after injection of dye. This is the osteotomy site, and this is after capsulotomy, labrum, and the blood circulation. So the whole point is to preserve this circulation. So this was the initial control X-ray after surgery. So posterior plates and head registered in place with lag screws put on the posterior fragment, and the osteotomy site fixed back. And this is the control X-ray 3 years ago, and as you can see, the hip joint is getting narrower and narrower with some arthritic changes. And this is the control X-ray like few days ago, and still, as you can see, there is advanced arthritis with degenerative changes going on. But still, this is the outcome of the patient three days ago. This is how he looks like on the video. So the hip score at this time is 88.95, still in good function, even though the arthritis is advanced. So the take-home message is, in resource-limited setups, primary fixation of neglected acetabular fracture dislocation has to be attempted so that the bone stock will be improved for ease of future total hip replacement and delaying THR in young people. So this is the whole concept of doing such surgeries in resource-limiting setup. Thank you very much.
Thanks, Getahun. Could you go back to your preoperative X-ray just for the conversation? And since Dr. Sami Hailu was the primary surgeon for this case, I'd love to first kick off the conversation with inviting him to speak and comment on this case.
Yeah, so this is one of the early cases that I did early on after fellowship. And it was one of the challenging cases. I think the pattern was like a transverse plus posterior fracture, where the transverse fracture part actually healed reasonably well, and the posterior fragment, as you see, has migrated proximally and posteriorly, and it was solidly united with gluteal pillar and posterior aspect of the acetabulum, as you see here. So basically, the main thing at that point was, in Black Line Hospital, we didn't have, the option to do a joint replacement, so we didn't even consider it, and we immediately discussed with the patient and went ahead into hip preservation intervention, and the digastric osteotomy and anterior exposure was it was easier to see the anterior aspect of the anterior aspect of the hip, and to clear the acetabulum side, the digastric osteotomy was the ideal approach for this sort of fracture dislocations. And after thorough cleaning, we obviously did the osteotomy, as Getahun mentioned. And maintaining the head in location was quite challenging because of the contracted soft tissues around. So one assistant was continuously holding it reduced while we fix the head. And of course, one of the advantages of doing the digastric osteotomy is bringing the head, the greater trochanter, into its bed will be much more easier, and you can actually maintain it as it engages like this. It helps in maintaining it in situ. And he's now 8.5 years out from the initial fixation, even though he has developed arthritis. He's functionally doing well, and delaying 8 years, maybe 10 years hip replacement requirement is, I think, something of an achievement for him. So he has been quite functional, and he's back to his journaling activity. He's a journalist, and he's doing well. So if you go into the hip replacement route down the line, it will definitely be an easy primary hip replacement. So it's something that we can consider for this sort of scenarios.
Fantastic outcome as well. Sushant, I see you raised your hand. Do you have a comment?
Yes, I just wanted to commend you, a brilliant case coming from there. My question is, we see a lot of such patients who come into us after a year. So I would like the presenter or the people from Ethiopia, what is your plan? How do you manage patients who come in after a year to you? Is there a change in plan? Do you straight away go for an osteosynthesis, or you think that as this is 1 year old, you want to go for a acetabular reconstruction? So how do you tackle that situation? Because I get a lot of patients in my practice here in the university who come to us with acetabular defects, basically traumatic after 1 year or 1.5 years. A young patient. So what do you do? Thank you.
Great question. Sami, would you like to answer that question?
Yeah, sure. So basically, after doing a couple of more cases of similar, delayed presentations, what I noted was, those patients who had, bogey head, which basically was intraoperative diagnosis of AVN, I started doing MRI. So any patient coming late now, what I do is, I get MRI. At this point, I didn't do MRI. To begin with, we didn't have any hip replacement option for him at that time. So we didn't even consider that. But now what I do is any patient young coming to me with similar, I get MRI and make sure, the head is viable. And also the acetabulum side, the cartilage is reasonably preserved, then I would definitely go and try to preserve the hip. But if the head has, a significant avascular necrosis on the dome side or the weight-bearing aspect, and if the cartilage is also damaged, then I would entertain hip replacement from the beginning. And obviously, the fracture, if the fracture is not a big chunk like this one, maintaining the head located and maintaining the congruity of the acetabulum might also be challenging. Then in those cases, I would consider hip replacement from the beginning.
I see that K-Rod has his hand raised, would love to hear his comments, but I also had a question about that. I mean, I know that, in pediatric cases, sometimes we have to do femoral osteotomies to shorten. Is that ever something that you consider, Sammy, if this is being dislocated for long periods of time? And do you worry about the sciatic nerve?
Yeah, so I try to do, when I get tight sciatic nerve, I do neurolysis, like basically, the adhesion around it, I do release. And I try to keep the length maintained whenever possible. But when I feel like it is quite tight, I would do, subtrochanteric shortening osteotomy, and I'll fix it with a nail and do that. But I probably had to do that, once or twice in the last, 8 years or so.
Great. K-Rod, go ahead. You had your hand raised, and then Mike, please, after K-Rod, perhaps.
Oh, no, I just wanted to say it's just a remarkable case with, technically done beautifully. And to claim that we would have this kind of experience, would not be true in the United States, because we hardly ever see these very late cases, and they get seen by someone sooner than many months go by. And because of that, because of the likelihood that this case will end up acutely in someone's clinic, the options for us of having arthroplasty and combined fixation are available. So I was wondering, now that if you have access to arthroplasty now, Dr. Sailu, would you consider doing fixation and arthroplasty at the same time, particularly in a patient that has been out for so many months, even if the cartilage is good? Because even in an acute situation, these posterior wall fractures very often end up with arthrosis. What is your criteria for a middle 30, 40-year-old person to do fixation and arthroplasty if you have that available now, versus just doing a fantastic repair like you did for this gentleman?
I think, even if I had MRI at that point with even signs of AVN, I wouldn't have hesitated to do what I did. But at this point in time, I would get MRI and see the cartilage, both the fractured side as well as the intact side of the acetabulum. If that looks good and also the head has no AVN, I would do a preservation. I would fix it, and I wouldn't do replacement even now. But somebody of 50 years or above, maybe my threshold for hip replacement will be low. I might consider fix and replace to begin with. But with somebody of his age with good cartilage and head, I would do fixation and see how he comes along down the line.
I'd also just add a comment to that in many parts of the world, we don't have access to revision arthroplasty, and the risk of infection, particularly devastating when there aren't skilled revision arthroplasty surgeons available. So I totally agree with the option of trying to preserve, having a higher tendency to preserve in these settings. We have 3 faculty with comments. Mike, I'll let you go first, and then Fahmy and Philip before we move on to the next case. Mike, go ahead, please. Oh, do we lose Mike Weaver? Fahmy, go ahead. Since you got your
First, I wanted to say, like, an amazing result and a really beautifully done case. You've done this patient a great service. I just wanted to address the question about the sciatic nerve a little bit. Nerves are a little bit different than a lot of other tissues in the body, in that they don't contract over time. And so the concern about lengthening the sciatic nerve really comes from the dysplasia literature, where people developed with a dislocated hip and the nerve never was at a normal length. and so it stretches it. So I think in a situation like this, absolutely a good neurolysis to make sure there's not any impingement on it is important, but it's safe to lengthen somebody back to where they were even years later. So we've had cases not quite like this, but for other issues where we've lengthened people, and it's safe as long as you are careful and decompress the nerve.
Great point, Mike. Thank you. Fahmy.
Excellent surgery, Sam. Very well done. Just a few points in this case that because it was 6 months out, the acetabulum was full of fibrous tissue, and I think the trochanteric osteotomy gave you a good visualization of the acetabulum to clear it out before putting the head in. As we know from the pediatrics world, especially in DDH cases, so the tendency of the head is go back to its original place. So in this case, being 6 months out and already it has like a false acetabulum. Once you reduced it, put it back in, what was your post-operative protocol for this patient? Did you put in him on traction? If yes, then for how long to prevent the head going back?
I have never put anybody for whom I have done open reduction on traction. I keep them non-weight bearing. For somebody like this, if there is a fracture that I fix, I try to keep them, non-weight bearing for at least 2 to 3 months. But if the head is unstable to begin with, I don't think traction would do much of a job. You might rather opt for another form of intervention. So I have never put them on traction after doing that. But I strongly agree on the previous comment that of a sciatic nerve comment. I have lengthened somebody more than 6 centimeters from post-traumatic condition, and I have not seen a symptom that mandates any further intervention. I think the literature definitely came from DDH experience. So I strongly agree with the sciatic nerve comment previously.
Sammy. Phil, last comment on this before we move on to the next case, if you don't mind. Gloria, you can get your slides up and running, and Getahun, you can take yours down in the time being. Phil, please.
Yes, beautiful case. I think for me, especially for the younger surgeons, the key teaching point is the use of the surgical hip dislocation and digastric osteotomy, because the main thing that it gives you is actually 3 things. Number 1, you can look inside the joint. Trying to assess the reduction from outside in a case like this would be almost impossible. Number 2, as was previously mentioned, you can clean out the joint. And number 3, you can remove the callus anteriorly. So I think that is the real key, beautiful move here in the preoperative plan. Bravo.
Excellent teaching points. Thank you all. All right, well, now I'll turn it over to Dr. Glory Sefu from Malawi. Glory, please go ahead. Glory, can you unmute yourself? We can't hear you.
Right, apologies for that. So I'll take you through the second case. This is a patient who had a neglected hip fracture dislocation. So of note, this was a polytrauma patient. He's a 35-year-old male who was involved in a road traffic accident. So was involved in a head-on motor vehicle collision. So he sustained a right acetabular fracture as well as a dislocation of the hip. Of note, he also had injury to his right tibia. So it was a segmental injury that was involving both the tibia plateau as well as the shaft. Of note in his history, there was no remarkable comorbidities. So when he was seen on examination in the A&E, primary survey, his A, B, C, D were cleared. On exposure, he was noted to have some small abrasions and a pinpoint wound on the right leg. However, his distal neurovascular status was intact. So the plans that was done intra-op after the x-rays were seen. So these were the x-rays that were done. You can see there's a tibial plateau fracture, so extending all the way into the condyles, as well as metaphysio-diaphysio association, which is consistent with the Schatzke 6. also had another fracture at the junction between the middle and proximal thirds. So in the A&E was managed with analgesia, was given toxoids, tetanus toxoid vaccine, as well as antibiotics, was splinted. Of note, the patient was also anemic, so noted to have an HB of 7.3, and he was given 1 unit preoperatively. The next day, he was taken in for XFIX as a knee bridging XFIX. Upon the completion of the XFIX, because it was only done the next day, there was no theater space the night before, unfortunately. It was then noted that the patient was complaining of other injuries. So the initial primary survey, an AP pelvis had been done, which noted the dislocation of the femur. So we went on to ask for additional views, including Jude views as well as AP pelvis inlet and outlet views. These were the views that were available to us, but as you can see, they do demonstrate the fracture of the acetabulum, which was a posterior fracture, as well as the dislocation. We were also able to acquire a CT scan, which gave us additional information that there were incarcerated fragments within the joint and further characterized the fracture of the posterior wall. Unfortunately, the patient still remained anemic, so had an hemoglobin of 8.4. So we weren't able to take him into theater for definitive fixation right away because he required optimization. This is often a reality for us in our setting because you do have patients who may have a low baseline hemoglobin to begin with or severe trauma and they bleed quite a lot. This is further complicated by the fact that blood reserves are not always readily available. So it took us about 2 weeks before we could optimize the patient for theater. After the transfusion, he eventually got to an HB of 12, and then we were able to take him in 2 weeks later, also given there was lack of theater space because of our high trauma burden. So when taken in, we needed to do some significant preoperative planning, obviously. He now has an XFIX in situ, and so you need to consider with the approach, are you going to be able to get the adequate approach with the XFIX right there? So we then opted to do a Coca-Langenbeck approach, and this was done in lateral, as we noticed that in prone, it wasn't going to be easy with the XFIX. So what we had done intra-op was to remove the bars and the clamps from the XFIX, but the Schanz pins and the tibia were kept in situ. We then went on to make sure it was flexed at 90 degrees to release tension on the sciatic nerve all throughout, made a curvilinear incision at the posterior superior iliac spine in line with the greater trochanter as well as the anatomical bow of the femur. Went on to dissect, and when we got to the joint, we placed a Schanz pin in the head of the femur. This was acting as a joystick to help distract the joint so we could remove the incarcerated fragments as well as fibrous tissue that were present. And then we were able to use the Schanz pin as a joystick as well to help aid with the reduction, of which we were able to get that quite easily, thankfully, and then went on to fix the posterior wall. So post-operatively, you'll see that we used an 8-hole recon plate as well as a 5-hole DCP. So we used them in bridging mode. We were able to reconstruct the posterior wall, and the femoral head was sitting in nicely after the reconstruction. So post-operatively, we did encourage early mobilization. He was on non-weight-bearing ambulation, as well as we instructed him to have hip precautions to prevent the redislocation of the head. In our setting, this also tends to be quite a challenge because of the fact that many patients will use squatting toilets or pit latrines. And the actions required for this will go against the hip precautions because they'll be flexing more than 90 degrees. They will have to abduct as well. So we instructed him to have a toilet seat raised that would be locally made. So this was him, 6 weeks. We saw him in clinic. Thankfully, the femoral head was still in place at the time, was healing quite well. You notice the knee bridging XFIX is still in situ. Unfortunately, there was medial translation after placement at the proximal fragment. However, the contours of the plateau are much better. We had planned this as a staged approach that eventually he would have a pin site holiday, and then plating, definitive plating could be done for the tibia. At 12 weeks, he came back. Unfortunately, the femoral head did not stay in its place. He had not been able to keep the toilet seat raised. The one they had was damaged, and they weren't able to get another one. So eventually ended up redislocating. You can also notice the osteopenia in the proximal femur as compared to the left side at this point already. However, we were able to have the X-fix removed and gave him a pin-side holiday, giving him a chance for further definitive surgery in the future. But at this point, the patient had declined for any further surgeries at this point. He was currently ambulating with 2 crutches, had started to weight bear on the leg, is ambulatory with a bit of pain on the hip, but otherwise the leg and the knee, he says he's not in pain and is satisfied for now. So on follow-up reviews, we're going to discuss the possibility of further surgeries. But the take-home message for this case and this patient was preoperative planning is important. It needs to be tailored to the patient that you have according to the way they've presented and all of the other things they have in place. As well as the importance of recognizing comorbidities to make sure the surgery is as safe as possible. You optimize them, much as you want to do your fixation nice and early, but you don't want to put the patient's life at risk. So it's important to holistically manage the patient, as well as need to make post-op care plans that are tailored to low resource settings. So especially in this case, thinking about hip precautions post-op and how to make it feasible for the patient with the resources available to them. Thank you.
Thank you, Glory. Can you go back to the preoperative X-ray of the pelvis and acetabulum, just for the purposes of discussion?
Sure.
Very difficult case. We selected this one because it represents the other side of why these cases can be delayed in a resource-limited setting. You know, the first case presented by Dr. Getahun showed a patient who presented to the hospital very late. This is a patient with a polytrauma who presented right after the injury, but was delayed for a number of factors related to resource limitations of the hospital itself and also the severity of the injury, which resulted in delayed surgical fixation. My question to you, Glory, is why do you think that the patient redislocated in follow-up? Do you think it had to do with having to squat to use the toilet and not being able to observe the posterior hip precautions? Is that why?
We think so because everything else he says he's been able to follow. When standing up from sitting, he was always making sure to extend the leg. But we think the main issue was the squatting as he was using the latrine, because they said with the toilet raise that they had been able to acquire previously, that was helping. Because you can see at 6 weeks, it was still sitting in nicely within its place. But after it was destroyed and they weren't able to get another one, we think probably it was difficult for him to maintain adherence to the hip precautions.
Yeah. Sushant, you've raised your hand. Do you have a comment on that?
Yeah, a great case. I can understand it's difficult to manage this, but I have a question for you, Glory. What would you have done something different? I mean, I beg to differ on the management protocol. I would have loved to go ahead and span the knee, if possible as well, because we had a proximal tibia fracture as well. So would you have considered that? You know, because if you see post-op, if you go ahead and you see that there's almost good alignment which has been maintained in the, you know, the metaphyseal, diphyseal region, and the lower 1/3 shaft has almost, you know, united very well. So if we could have, you know, really gone in, put some pins on the proximal tibia area and span the knee, I guess that would have made some difference. Any thoughts or comments from the faculty on this?
Great question regarding. Go ahead, Glory. Sorry.
Yeah, sorry. I was gonna say we did span the knee. So as you can see, we do have some pins in the distal femur as well. So we made sure to capture the femur and then the diaphyseal fragment as well as the distal fragment that has that. So it was quite a bulky X-fix.
I've seen cases, I think that Dr. Fahmy and Dr. Pierre-Marie have shared where they do skinny wires proximally in the tibia and then can, instead of spanning the knee, you're just able to focus fixation just on the tibia. And I wonder if in a resource limited setting where you may not have all the plates and, you know, facilities to fix the tibia early, that may have been a good option here. But I'll hand it. We're going to be talking about tibial plateaus next week. The focus today is mainly on the acetabulum. I'll hand it over to Philip, who had his hand raised.
Yes, I think you've done a great job of saving this patient's life and getting him back on his feet. The second case I ever did in terms of an acetabular fracture, I had a very similar situation. If you can hold these x-rays right here, I do, however, have a teaching point. When I see, if you look at the iliac oblique there, I think optimally, what one wants to do is to curve the plate anteriorly to maximally buttress the posterior wall. And so I certainly understand the situation in terms of the hip flexion precautions, etc. But I would make the provocative statement that perhaps we don't need hip flexion precautions at all if we have a really adequate buttress, which can be challenging, and as I said, happened to me as well. But I have two concerns of when the plates go up above the greater sciatic notch. I'm concerned about the superior gluteal nerve, and I'm also concerned that we haven't curved the plate on the flat so that it goes anteriorly to adequately buttress the fracture. Can be very challenging and easy for me to be perhaps slightly critical now that I've seen what happens, but I think that's a good key teaching point for me from this case. Thank you for sharing it.
Thank you, Philip.
Thank you very much.
Paul and K-Rod, did you guys have comments? Paul, you want to go?
Yeah, I can comment quickly. I think, Lori, that was a great fixation of the acetabulum. It looked very good, but I think you were doomed from the start because the patient had a huge X-fix on. Like, imagine the stress on that hip when they can't do precautions with an X-fix on. So, I mean, I think you fixed it very well. It's if you had been able to fix the tibia, I think it would have been perfect. That would have taken the stress off of the hip, but I'm guessing that was because you didn't have plates, etc. right away, or the skin was not good.
Yeah, the skin wasn't good. We wanted the abrasions and the soft tissues to settle, so it was too risky to go in with the definitive management at the time.
Yeah, I mean, I think your acetabulum was fixed beautifully, but you're doomed because they are just making the stress on it even worse with that X-fix on.
Yeah.
K-Rod? You're muted, K-Rod.
My apologies. Great, great repair, and the fixation technique is very sound. Could you go to the initial post-op film? Could you maybe? Okay. And could you go now to the first film where we have failure? So the hip is subsiding again, and the little transverse plate, that's just a great way of enhancing the surface area, has pivoted, right? But one little technical trick is, you don't have screws on the transverse plate, so you've allowed the plate to be free pivoting, and that's a little bit less mechanically sturdy than if you had put a screw and turned that plate into a more fixed device. So what happened, I think, is the stress on the hip, because the patient was in an X-fix and squatting and doing things like that, allowed for that plate to shift under your buttress plate. And sometimes linking those two together and putting a screw on the more medial hole will prevent that plate from spinning, and maybe all you need to protect it a little bit more.
That's a good point.
Right. Thank you.
And I think that sort of goes in line with what Philip was saying about the angle of that plate and trying to get it to stay in the location where it's adequately buttressing that fragment. I see a couple of other hands up. I just had another comment. In cases where the posterior wall is a mess, it's very small, multifragmentary, and especially in these delayed cases, if you're trying to do hip preservation, is there a way that you can use iliac crest to supplement the fixation to create more of a buttress there? Is that ever something that you consider? to any of the faculty?
Yeah, actually, just a few weeks ago, we had a patient with that kind of an injury. So had a defect on the posterior aspect of the root. So we did a harvest of the posterior iliac crest because he was already in prone position within Koka back. So we used a piece of the iliac crest and fixed that, lagged that to the acetabulum, and that kind of created an overhang. So that was helping the femoral head sit in its place.
Brilliant. Naresh, you've got your hand up. Did you want to make a comment?
Yes, thank you very much, Kiran. Just a small comment. I just wanted to share our experience in such cases, though I'm going to talk in a little bit more detail in the next week's session. Now, this fracture on the leg, the tibial plateau cum metaphyseal fracture and a diaphyseal fracture, we have been doing such fractures with a nail from top down. And even in open fractures and with poor skin conditions even, and that has helped us quite a lot. But I would have done in this case, day one, closed nailing. With no proximal would not be completely closed, but I will talk about the technique next time. We just convert the condylar fragments into one fragment by percutaneous screws, and then give a midline incision, open the knee and shove a nail down. And that fixes all the fractures. And I'm going to share that. And that leaves the leg and the knee free, and also hip without any undue, biomechanical disadvantage. So that is just, I wanted to share it, though I'm going to talk about it next week's talk in more detail, the technique.
Thanks, Naresh. Yeah, that perhaps would have helped with the posterior hip precautions and all that, as Paul was saying. Haley, you had a comment?
Yes, there's just one question in the chat about the initial management and whether there was a closed reduction that was attempted or if the hip was irreducible because of those incarcerated fragments, and then whether there was any traction that was applied through the X-Fix system.
Okay, so there was an initial closed reduction that was attempted, but it was failed. So which is then why we decided he's going to need an open reduction, but was delayed because of that. Sorry, the last bit was, I didn't quite catch that.
If there was any skeletal traction, so either through the X-Fix or a separate pin that was placed in the distal femur while he was waiting to go to the operating room.
So he had a calcaneal pin here.
Okay.
Yeah.
Great point. And also you had intra-articular fragments and all that, all that to consider about the reduction and the traction. There's a hand raised from Ebsu. Ebsu, did you have a comment before we move on to the next case? Gloria, you can take your slides down while we get the next case going. Dr. Mahmoud Fahmy can get his slides up.
Yes, can we use a spring plate instead of that recon plate used without screws? Would it add any biomechanical stability if you just a spring plate?
Any comments from the faculty on that question?
I personally, I think the use of that recon plate was an attempt to use a spring plate, and I think it probably would be biomechanically as strong as a spring plate. That would be my comment on that. The other comment that I would make is, we just saw a beautiful case of a surgical hip dislocation. I haven't studied this film enough, but this might be a case which allowed us to get anterior and see inside the joint to really see the fracture perhaps more optimally. That's another thought, I think, for this situation.
Thanks, Philip. Dr. Mahmoud Fahmy, are you ready to present?
Yes, hello.
Hi.
Yes, I'm ready. I'm trying now to share.
Great. Just as we're getting Dr. Mahmoud's slides up, I would just ask one last question of Glory for that very challenging case. What's the plan now for that patient? What are you hoping to do? Like, are you planning to leave the hip as is? Are you planning to maybe wait for arthroplasty someday? What's your plan for him?
Mm. So in the long run, currently he doesn't want any further surgeries as he was seen in the last clinic, but we told him that when he does decide that probably he might need a hip replacement, so an arthroplasty down the line. Occasionally we do have camps that happen, but we told him it's gonna be a dicey thing whether the availability will be there or not. So if he would make up his mind, probably sooner than later would be a better decision.
What's the functional status? You said he's ambulatory and able to do what he needs to get around the house and that sort of thing.
Yeah, so he's using both two crutches at the time, just has a little bit of pain at the hip, but he says his knee is fine. Flexion at the knee is about 20 degrees, extension to 0. He's undergoing physiotherapy as well at the hospital, so he's coming every now and again. But he's still limited in that he's not able to go back to work, for example. He's a truck driver, so his means of living is currently on hold, unfortunately.
Very challenging. Thank you, Glory. Thank you
Yeah.
for taking that case. We learn so much from these complex cases. Thank you. I'll hand it
Thank
over
you.
now to Dr. Mahmoud Fahmy. Please go ahead, Dr. Mahmoud.
Okay, thank you very much for the organizing committee and for you. I am Mahmoud Fahmy. I'm Associate Professor of Orthopedic Surgery at the Cairo University. I'm going to present a case of neglected central hip dislocation with transverse posterior wall. This patient is a female patient, 49 years old, that was admitted to the ICU for a medical cause, and it was neglected. They didn't recognize this fracture, although was acute shortening in the limb, but for some reasons they didn't recognize it, and that it presented to me with this picture as a huge callus is formed around the head with this central dislocation. As you see here in the CT 3D, there is a posterior wall fracture, there is a transverse fracture of the acetabulum, and there is a huge callus formed anteriorly and posteriorly around the head. When we see the coronal cuts of the CT, we see that the femoral head is completely indented by the sharp edges of the acetabulum, and there is also a huge callus formed here around the head anteriorly till the posterior part of the acetabulum. So what is the problems I think about this case? First of all, it is a neglected fracture. There is a lot of callus adhesions. It's very difficult to mobilize the fragment, especially this case has a neurological problem which increase bone formation around the fracture. Also, there is a shortening, as I told you. This huge callus formation, although the callus is due to a neurological brain hematoma, makes it harder to see the fracture line and even the reduction. Also, the femoral head indentation makes it very difficult to be relocated even after mobilization of the fracture edges. So the options I think about is first to do a total hip replacement without fixation, but this will need a very huge reconstruction of the acetabulum, and also it needs a huge bone callus to be formed, and it's only 6 weeks. I cannot guarantee that the callus formed can make me safe to perform the total hip acutely. The second option is to fix and to do the acute total hip replacement. And the third case is to fix and to delay the total hip replacement according to the patient general condition. I choose to fix and do acute total hip replacement, but I need to do a very precise preoperative planning and putting plan A, plan B, plan C. My first plan was to do an ilioinguinal approach in order to remove the whole surrounding callus around the femoral head and to mobilize the fracture fragments very well. The second plan is to do intrapelvic head osteotomy if the head is not reducible by the traction, either the lateral traction or the axial traction. This head will not be reduced. It takes the shape of the indentation of the acetabulum. Whenever you put a traction on this head, it will not be reduced. So I must do an intrapelvic head osteotomy either in incomplete piece or piecemeal. The second one is fracture mobilization and fixation of the anterior column, buttressing the quadrilateral plate, and finally turn the patient to the lateral position to fix the posterior wall fracture and put the primary total hip replacement with minor acetabular reconstruction. Okay, this is the first step I did. I did the ilioinguinal approach, removing the whole callus formed around the head and fixing the anterior column and the quadrilateral plate using the buttress screws technique. I also performed a piecemeal head osteotomy as it is not reduced by any means. And this is the iliac obturator view. And then I go to the posterior approach, fixing the posterior wall and putting a cementless total hip replacement while doing a small impaction grafting in the floor of the acetabulum. This was the immediate postoperative X-ray, as you show, the plate anteriorly fixing the anterior column, the plate posteriorly fixing the posterior wall, slight impaction grafting in the bed of the acetabulum, and the cementless press fit total hip replacement. And here is its X-ray after 1 year. She is now fully weight bearing. Modified Merle-Belier score is excellent, and she is doing well in her daily activity living. So my take-home message is always take care of the neglected fractures. Please screen the patients. And if you find a acetabular fracture, please put it in a traction or fix it as soon as possible. And if you're facing a neglected fracture, please try to fix it, try to have a good reduction fixation, because this restore the anatomy and at least it decreases the reconstruction of the acetabulum that you will need. And the last, and it should be very important to do a pre-operative planning and put for yourself a plan A and plan B and plan C for every event that can occur intraoperatively. Thank you very much.
Thank you, Mahmoud. Can you go back to the preoperative X-rays just for the discussion? We haven't heard from a couple of faculty here who I'd like to bring into the conversation. Mike, sorry, just before you make your comment, if you don't mind. Dr. Isaac and Dr. Mai, I don't know if you had any comments for this one that you wanted to share. Isaac, I know that you've had a few cases where you've been fixing and replacing. Curious if you had any comments on that.
Yeah, I mean, Dr. Fahmy, this is a great case, and I commend you on an excellent clinical result. You know, obviously, this is a very challenging situation in a relatively young patient. The question I would have is, you know, in converting this to a total hip replacement using a press fit technique, what was your plan B if you were not able to get that cup to seat properly and achieve a good press fit fixation?
My next plan is to go to cemented total hip replacement, either on dual mobility or a primary cup. But if it is not going to be a cementless press fit, I would go for a cemented total hip.
Mike, did you have any comments on that?
I think this is amazing. Oh, sorry.
Go ahead. Please go ahead.
I couldn't hear it was Mai or Mike, very similar name. This is an amazing case, Dr. Fahmy. And I think that even in high resource setting, I think we will approach it the same way like you did. Combinations of fixation, trying to preserve the bone stock so that you can have a surface to rest your cup in. And then based on all the images you show, I don't think that femoral head have a chance to survive at all. So I think that this patient will do much better with a total hip versus just getting that head melt away overall. Excellent case.
Thank you very much. Thank you very much.
Thank you, Mai. And now Mike, did you have a comment?
Well, I just again, a very beautiful case, and certainly a challenging one given the delay and the callus. And I think it illustrates the key principles of this. Almost all of these cases can be treated with a press fit cup if you did what you did, which was restore the anatomy in the columns. It doesn't have to be an anatomic reduction of the columns, but it needs to be a good reduction of the columns, and they need to be securely attached together so that you can have two hemispherical or two sides to grab onto that cup. And then obviously if you have the ability to use more sticky cups, we would call them here, like trabecular metal or titanium cups, that's good, with multiple holes with screws if you can. But a beautiful illustration of the principles of these cases. We've in the United States, we do a lot of fix and replace, not necessarily quite in this situation for delayed fractures, but for acute fractures in geriatric patients with comminution. And this illustrates those principles very beautifully.
Thanks a lot for your comment. Thanks a lot.
Sushant and Vishnu both have their hands raised. I'll start with Sushant.
Prof, brilliant case. I just had two doubts. How do you manage cases wherein you have a neurovascular deficit? Do you go ahead for a CT angio, or you prescribe for a color Doppler? Is that the routine thing which you do? And what were the other technical challenges you had in this case? Was there any neurovascular problems in this case?
For sure, if we have a doubt in the neurovascular state, we should go with CT angio because the callus may be very close to our approach, and especially I use the ilioinguinal approach, which I dissect around the femoral canal and the femoral vessels. But this patient does not have a neurovascular problems preoperative or postoperative, so we didn't do this investigation.
Thank you. Thank you, Prof.
Thank you very much.
Really great point, Sushant. Thank you for that. Vishnu, yes, you've got your hand up. Please.
Yeah, I also just wanted to emphasize on that, because these fractures generally, when you're doing a preoperative planning, the CT angio is very much, because if you're going through a posterior approach, the superior gluteal vessels are very near the posterior column fragments, so that intraoperatively the injury of the vessels is it's also an issue. And also you should keep a watch out for the vascular surgeon nearby if anything needed, because these all are the callus is very much deep inside, and so when are you mobilizing the fracture fragments? So there is this. So is there any role for if you are not able to, because most of these they have also the posterior superior defects also will be there. Is there any role for any where the head can be used as a graft, and if you need for, you can do for a cup placement, role of femoral head grafts, or a role of iliac crest bone grafts preoperatively or intraoperatively when you see such a big defect?
Yeah, for your first part, yes, a vascular surgeon should be on call and should be very close to my room because it's a very lengthy procedure and long, and maybe anything can happen. So it was standby, but as I told you, the preoperative didn't show any neurovascular affection. By the way, I was afraid more from the anterior compartment affection, the femoral vessels, during releasing and mobilizing the fragments rather than the posterior gluteal, because the posterior wall, I can fix it without going so posterior towards the greater sciatic notch, so I will not be approaching the posterior gluteal vessels. Regarding your second part, is there a superior lateral defect? This is the main idea for fixing this fracture. This fracture decreases a lot the reconstruction you need to do. If you didn't fix good, not anatomical, but at least good, showing that the both columns are approaching each other, you may need to put the femoral head or a tantalum augment, whatever you will use. But because I tried to do an anatomical reduction of both columns, this helps me not to use any reconstruction regarding the femoral head or the metal augment.
Mike, last comment before we move to the next presentation.
Yeah, I'd just add that not in this case, but your question about the femoral head is a very good one, particularly in comminuted posterior wall fractures where there's a lot of marginal impaction. In those situations, there often is not a lot of bone stock back there, and that's more of a geriatric problem. But then bisecting the femoral head and using it as a bulk allograft is a great technique, buttressing it in place just like you would a posterior wall, and then that gives you the bony bed that would accept the cup.
Thanks, Mike. And
Yes,
since you
this was one of my plan. This was one of my plan. If this posterior wall was resorbed and not be able to fix it, I was going to use the femoral head as you told me, but fortunately it was able to be fixed, and I used only some of the femoral head as an impaction grafting for the bed.
Thanks, Dr. Mahmoud. As we transition to the next one, you can take your slides down, Dr. Mahmoud, and Dr. Mohammed, if you can get your slides up. Just two questions, Dr. Mahmoud, from the audience. What about the sciatic nerve? Was that a concern of yours in this case? And also, what about stoppa and posterior approach? Did you consider doing that?
Yes, sciatic nerve was one of my concerns for sure, because there is a shortening and there is a posterior element fracture. But after mobilization of the fracture anteriorly and the piecemeal osteotomy of the head, it decreases a lot the traction posteriorly, so it becomes safe. The second question was about what, sorry?
The approach that you chose. Why not a stoppa?
Yeah, modified stop approach could never let me release the callus that is formed very aggressively around the head. Also, I cannot approach the quadrilateral plate from this view. It can be helped in acute fracture, but in neglected fracture, you need to be meticulous and mobilize the vessels in order to show the whole configuration of the acetabulum underneath and reduce the fragments under your eye.
Great teaching point. Thank you very much. We'll just
Thank you.
Thank you. For the purposes of time, we'll now hand it over to Dr. Mohammed from Sudan. Please go ahead. The floor is yours.
Thank you very much, Karen. Thank you very much for being here. It's my great pleasure. I will be presenting a case of chronic anterior hip dislocation, the pubic type, treated by total hip replacement. Just for you, those does not know where is Sudan. Sudan is just situated south to Egypt in the northern and eastern part of Africa. This hospital, where I used to work in, it is out of service, unfortunately, for the last 2 years because of the conflict in Sudan. It used to deliver great services in different subspecialties of orthopedics, Sharganil Hospital. This is one of the latest pictures of the hospital. And this is my University of Khartoum, Faculty of Medicine, which was instituted in 1924, a great institute of more than 100-year history. Back to the case, this is a 26-year-old female with incidental finding of type 1 neurofibromatosis. She fell down 1 year prior to admission. She fell off a camel, and she presented with a neglected right anterior hip dislocation. As we know, anterior hip dislocation is not that common. In my career, I've seen it twice. The inferior type, the obturator one, I've seen it once in my life, and this is the second case. It was the superior one, the pubic type. She came to the outpatient clinic. She was walking in with a stick. There was a shortening of about 4 centimeters, and the femoral head was palpable at the right groin. There was no distal neurovascular injury. She had a supple equinus, not fixed. The X-ray showed the diagnosis, and we requested a CT scan for preoperative planning. So if you can look at the 3D here, you can see the pubic head, the femoral head on the right side here is resting on the anterior column, as you can see, and it looks unhealthy. Of course, we have to confirm that with MRI, but we didn't do that. So you can see here on the left lower side, that's the acetabulum. It looks fine. This is also 3D. On the cuts, we can see that the acetabular wall, at least we have a good anterior wall and posterior wall, and the columns as well. So we ask ourselves why these patients with delayed presentation, why they come so delayed for this young patient, and she's so active, and she come after 1 year of her condition. There are so many factors here. We know that these are remote areas with limitations in orthopedic surfaces. This nice lady, she came from far west part of Sudan. Financial issues, the health system here, they don't have full coverage, especially for orthopedic surfaces. And even if the health system can cover the operations, they don't cover the device. And we know that the orthopedic devices are a bit costly. Still, there is a very strong belief in traditional therapy, including the traditional bone setters. They have a very powerful role in the community. And I always say that we respect their role as they can deliver some surfaces, but the problem is sometimes they don't know their limitations. So we are surgeons, for example, we know that, for example, you can see a patient and you know you cannot deliver the surface for this patient, so it is not a shame to refer him for someone else. But the problem with the traditional bone setter, no, they don't know when to say, no, we don't do this. Limitation of the equipment, these are the challenges in this case. So the limitation of equipments, total hip replacement itself is a very, for patients to say that we want to do total hip replacement. So we are talking about very big problems. So they have to prepare themselves financially. And if we need any special equipment, for example, like a dual mobility augments, that means extra costs. So you have to consider this in your mind. The preoperative challenging in this case is how to restore the native center of rotation with such significant shortening. I do believe, like my colleagues mentioned earlier, I wouldn't say easy, but it is easier to restore a limb to a native preoperative position as the soft tissues would allow that. It is not like when we are speaking about patients that having DDH. As bone defects that need any bone defects in preoperative management, also preoperative assessment, you have to assess whether you have any bone defects that need special care. So I can see from the CT scan, maybe from the cuts and from the 3D and the axial cuts, we might say this is an acetabular defect, which is superior with adequate rims. So it might be considered like Paparoski type 2A. So the good thing about this, it can be reconstructed with just a fully porous coat cup. And even if you need any bone graft, you can take it from the excised head with some screws, with some plates, so that would be manageable. So your goal for this patient, if you go for total hip replacement, that you want stable, durable implant. So what we did is we used the modified lateral approach, and we did for her a cementless ceramic on ceramic total hip replacement. Postoperatively, she had equal limbs, no foot drop, and partial weight bearing was encouraged from day one. She passed through normal postoperative care. After 2 weeks, the stitches were removed and home-based physiotherapy was done. After 2 months, this patient was able to walk without pain, and she was able to do single raise, leg raise. There was no Trendelenburg gait, and there was no growing pain. So these are the x-rays after 2 months. We can say that she has a good, well-fitting total hip replacement, cementless on the right side. So for summary, chronic hip dislocation is common in Africa. Delayed presentation is a trend with many challenges, and the options of management are different. So some colleagues might say that why wouldn't do reduction? For me, I wouldn't accept to do a reduction for a patient after 1 year. I saw this patient at the beginning of the year, like January, and she was ready for the surgery at April. So we are speaking about 15 months left since the first incident. Pelvic support osteotomy might be one of the options, but personally, I wouldn't believe about it. So some of the surgeons would say that it can equalize the limb, it can improve the Trendelenburg gait, but it results in changing in the anatomy of the proximal hip, and it will make total hip replacement very difficult later on. And still, it is not a native joint. So careful, well-planned THR can result in a very satisfying results, especially in young patients. Thank you very much.
Thank you, Mohammed. Could you go back to the preoperative X-ray just for the discussion? As someone who doesn't do pelvic and acetabular surgery and is very curious about the approaches for this, compared to the approach that Dr. Getahun presented at the beginning in the first case, how did you get the hip relocated? You know, could you tell us a little bit about the surgical exposure and surgical approach that you used to do that? And my second part to that question is, how did you confirm stability of the hip to prevent dislocation of the prosthetic hip once you place the total hip in there? Any comments on that?
Okay, it's different approaches. So I think you can go for the approach that works good on your hand. So my experience is good with the modified lateral approach. About accessing the head, it wasn't difficult because the head was palpable in the groin area. So for accessing the joint and the head was easy to excise the head and to get inside. The problem is how you can restore the native center of rotation and how to get a stable joint without any difficulty. So it is not a credit to have a stiff joint because it will result in painful prosthesis and dislocation. So what we did is a modified lateral approach, excising of the head, intraoperative assessment for the columns and for the walls, and it was absolutely fine. So there was no need for reconstruction with any autogenous bone graft from the excised head. You ream as inferior as medial as you can. Maybe I would be happier if the head that I use here, as I remember, it was 44 size, but I would prefer a 42 because if you can see from the postoperative postoperative case, the head is a bit bigger, but that was the smallest available size because I would prefer to put a smaller head and to make it more close for improving the stability of the head, of the implant, of the prosthesis. So that generally, regarding the reduction of the joint, you have to do careful soft tissue release regarding the capsules, regarding the adductor and the iliopsoas itself. You might consider the subtrochanteric osteotomy, shortening femur osteotomy, but as we said earlier by some of my colleagues, and personally, I believe that it is easier if you do careful soft tissue dissection, you can restore the native center of rotation and reduction without any problem, without need of doing osteotomy.
Thanks, Mohammed. I got hands raised from Jack and from Philip. Jack, you want to kick it off first? Oh, it looks like we lost Jack, maybe. Philip?
Yeah, great case. Mohammed, any assessment of the external iliac artery and vein? It would seem to me, as somebody that doesn't have the experience that you do with these neglected cases, but looking at that femoral head, that it may be very intimately involved with that. How do you assess it preoperatively, and then how are you prepared for that if the disastrous complication occurs in taking out the head? Maybe you could teach us all your thoughts on that.
Well, actually, we do the clinical assessment first. Actually, I don't ask for a CT angiogram unless I feel that there would be a real problem. So what we do is a careful approach, and the head was mobile, so it wasn't like fixed to the column. So it was easier to dislocate it more and to excise the head carefully. But probably, if you have any doubt or if you feel that you will have any trouble, it is better to ask for a preoperative CT angio and maybe to have some backup with some vascular serum beside you if you expect any troubles. But for this patient, it was easier to excise the head and to mobilize it carefully with careful soft tissue dissection, because it was already mobile, not fixed to the hip.
Great point. Jack, your hand is back raised. Sorry, I missed you the first time. Go ahead.
Yeah, no, not at all. Just a couple of comments. This is a really nice case. And yeah, it's really hard to beat the results of a good total hip replacement. I think it's an unusual case in that if you look at the CT that you've got up there on the screen, this is really, it looks like almost an isolated anterior wall fracture. So, pretty unusual pattern. And if you have a bad protrusio deformity in an older person, you have to be a lot more careful. In this case, the posterior column, the superior dome, most of the anterior column, all that's intact, which really makes your arthroplasty fairly straightforward. And I think it's a great choice in this case. Be careful about, taking a look on the plane films ahead of time and making sure before you go into arthroplasty, for the people in the audience who don't do a lot of this, make sure you're identifying your acetabular fracture correctly and treating the acetabulum correctly. Just putting a cup in here is not a panacea. It's not a guarantee of a good result. You have to make sure that you've got your cup well positioned. So be a little bit careful on that. And I would say also, on the issue of subtrochanteric osteotomies, in young patients, as Mike pointed out, as some of the presenters have pointed out, there's a lot of plasticity to that nerve. If you have an older person with a bad protrusio deformity and a hip flexion contracture, you have to be super careful about bringing this back out to length, pulling the head out, and trying to restore the length perfectly. You're better off leaving them a little bit short, correcting half the deformity if you're giving them a total hip replacement, than giving them a sciatic nerve palsy, because you can't recover from that. So just a word to the wise, older patients have a lot less plasticity to their sciatic nerve than young patients do.
Thanks, Jack. Sushant and then K-Rod.
Yeah. Hi, great case. Just a technical point. Do you believe in your practice of using, a skeletal traction to bring about easier reduction of the head? Do you do that normally in your practice for such cases?
Okay, thank you very much for this great question. Me personally, I haven't tried, but one of my colleagues, especially in patients with DDH, they used to do the total hip replacement like as 2 stages. So the first stage, they will do like ligament access or like soft tissue relaxation with an LRS or laser off until they bring the head closer to the acetabulum. Then in the second stage, they will go for primary total hip. So yeah, I definitely agree. It will be great, especially for patients with very great shortening.
Very great point. K-Rod, did you have a comment?
Yes, it's related to the, having never faced a challenge like this, my concern was also the vasculature, right? And I just have a technical point question. When you were reducing this or removing the head from the position that the image illustrates, did you do your reduction before you, did you do your neck cut and then took the head out, carefully dissecting around it? Or were you able to retrieve the head and the neck and the femur by manipulating the limb itself? I just worry that after a year, the scarring in the area would put the vessels at risk, and I'm not too sure how I would do it, frankly. That's why I'm asking just for my education.
Thank you very much for this question. This case was challenging for me because maybe this is one of the few cases that it was like bizarre. But when I get inside, the funny thing is that the head is so mobile. So I would expect that I have to do a lot of dissection. Maybe I might encounter some vascular injury. There may be so difficulty with retrieving the head, but the easiest part in this procedure is how to get the head outside and to cut it. So it was totally mobile, and I don't know why it was totally mobile. Was easy to retrieve it and to do osteotomy without any problem.
Thank you.
Welcome.
Yes, we selected this case because it's quite unusual for this anterior dislocation. As Dr. Dwayne Anderson presented in his lecture, which is available to all the course participants, and we can post it in the chat here. Obviously, the most common dislocation is posterior, but this anterior dislocation, I think, is wonderful teaching points here, Mohammed. Thank you for sharing them. As we transition to the next presentation, I'll invite Dr. Biniyam to put his slides up on the screen. If I could just ask maybe Dr. Sami Hailu and Dr. Fahmy to make a comment on this last case, because I know that you probably have some things to say about this. Sami, any comments on that last one?
So I guess obviously, this patient on the CT scan seems to have a clear avascular necrosis, and I think the decision to do a hip replacement is a proper decision. And in terms of approach, lateral approach will definitely give a good exposure. I don't think this is something that can be done from posterior, obviously, but anterior approach could also be a consideration if the surgeon is comfortable doing the anterior approach, because with the anterior approach you can actually keep your vessels far away from your surgical area. Especially, he got lucky because the head, he said, was mobile. But if the head was not as mobile as he found it intraoperatively, anterior approach would have been definitely a better one to keep the vessels, neurovascular structures away from your field of surgery. And, in terms of, so can I ask a question? Was there any reason why your offset is, decreased? Was it because the reduction was difficult? You used smaller head, or was it something not a planned thing in terms of maintaining the offset? Was it because your reduction was difficult? Sometimes when the reduction is very difficult, we tend to use a lower stem size and also a smaller head.
Well, I tried just to make the stem stable without trying to get a larger stem, so I will not face any problem with reduction. So I think if it is stable with just few shortening, that was my aim. If I get a stable implant with even few shortening, it would be better than trying to get a perfect offset with difficulty of reduction and maybe iatrogenic fracture.
What I was thinking was, if the head was mobile enough and if you have a good release, you could consider, building the offset and also lengthening if it was not. And if like the previous case, the offset was quite high. I think they used the high offset stem. It's in those cases maybe a consideration of double mobility cap from the beginning might be, I think, an idea to keep the offset reasonably balanced as opposed to the opposite contralateral side. Maybe from our Egypt colleague, he might give us a comment about that as well. It would be nice to hear.
True. Dual mobility cup would be a perfect option, but as I mentioned, to prepare a dual mobility cup, it needs some financial. It has some financial issue. So as I said, this patient, until she becomes ready for this surgery, she had to wait for 3 months. Dual mobility cup means that you have to request it. It has to be requested and to come, and they have to pay more. So that's why we had the belief that it can be done with ordinary total hip with some technical issues intraoperatively.
So you used high offset stem? Is that...
No, regular stem.
The regular stem, okay.
Regular stem.
Okay.
We just have one. Oh, sorry. Go ahead, Kieran.
I was just going to say, wonderful discussion, but we just need to move to our last presentation here by Dr. Biniyam, and then we can have a few more minutes at the end for those who are willing to chat a little bit more about all these. Great comments, though. Wonderful. Biniyam, please, if you don't mind, go ahead and present your slides. Please unmute Biniyam if you can.
Thank you, everyone, and welcome to the last case of the day. And I'm going to present a case which we operated while I was a trauma fellow at Black Lion Hospital like 4 years back. So this was a 40-year-old male farmer who sustained a fall-down accident, and he first presented to our clinic after 7 months of an anterior hip dislocation with all the disabilities. So we were able to get our imaging X-ray. At physical examination, they had a classic physical examination findings of an anterior hip dislocation, the hip being flexed, externally rotated and abducted. And we were able to get our X-ray and CT scan, and X-ray showed an Obturator anterior hip dislocation. CT scan showed us the the cartilage of both the acetabulum and the femoral head are eaten up. They were damaged. So we, the option was a possibility of, the option was either to get open reduction or arthroplasty. And by that time, there was arthroplasty service was started at the Black Lion Hospital, but it was, only limited surgeries were being done. It was by the help of our American friends. So we were not able to get him done. So he was on the list, on the logbook wait list for arthroplasty, for a total hip replacement. So he went back to his home and he showed up after 3 years. That means a total of 4 years from the initial injury. So during presentation, we had our so this was, we had a clinical video demonstrating his situation. This was his presentation. So before surgery, so this was a CT scan. His CT scan, as you can see, the head has tucked, like the one of the cases which was presented. It has tucked. It was engulfed inside the obturator foramen, and it has tucked. So we prepared him for a total an anterior approach, totally arthroplasty, hip replacement. So we took him to the OR, and we used the Hooter modification of the Smith-Peterson approach, and we were able to identify the site of the dislocation. And we tried to mobilize the head, but we found it a little bit, it has tucked. And we just made a cut, a neck cut, and we left the head inside just without removing it. We proceeded, we cleaned the acetabular fossa, and we performed our replacement. And this is a control X-ray for the replacement. And after a year or so, this is a final video of the outcome. And functionally, he's doing well, very happy. And we were able to see him in our follow-up clinic. So this was all. So you can proceed to, the surgeon was Dr. Samuel Hailu. I was an assistant. So I will leave the floor for Fahmy to lead the discussion. Thank you.
Thanks, Biniyam. Excellent case, and interesting that you left the femoral head in place. Much less risk, I guess, try to extract it. Sammy, comments on this one, since this is your case?
This patient came initially, 7 months after the dislocation, but we actually initially admitted him for salvage, and when we thoroughly evaluated his head, initially I thought the notch that you see was on the anterior side instead of the superior side, but with reconstructed CT scan image, that big head loss was basically on the superior anterior side, so it's basically on the dome. So, and also the cartilage aspect of the acetabulum side was not well preserved. So then we discharged him and telling him, to come back for hip replacement after putting him on a wait list for hip replacement. And after the anterior approach, we did our napkin cut, and then we really tried. Well, before the neck cut, we tried to dislocate to disengage the head. But as you see, you know, the head was well sitting in the obturator foramen. So we did a napkin cut to create room, and we used the corkscrew and everything, but we were not able to disengage and remove it. And you know, we didn't attempt to do piecemeal because, you know, osteotomiting it medially, you know, we were not comfortable. We didn't think it was you know, safe enough to do piecemeal removal, so we left it in situ, and we proceeded with our you know, hip replacement. And we didn't get, you know, the latest follow-up 4 years, but the video that Biniyam just shared you was 4 years after the surgery. He's back to farming. He was not able to come back for follow-up, but he sent us a video on Telegram.
Thanks, Fahmy. There's a comment in the chat about the component, the acetabular component being a little horizontal, worrying about risk of impingement. Any comment on that?
Yeah, so yeah, it is a little bit horizontal, but you know, as you see, the offset is quite enough, and risk of impingement is not that much. I deliberately did it a little bit more horizontal to just maintain the stability, because you know, in Black Line we don't have, you know, lip liner, we don't have double mobility, or we don't have any constraint liner. If the head is unstable, you know, we don't have much option. So that's why I try to keep my caps a little bit more horizontal than what what I normally do in scenarios when I have all the backups.
Thanks, Sammy. Great points. Few hands raised here. K-Rod, Fahmy, and Isaac, maybe in that order. K-Rod, you want to go first?
Yes, thank you. Very interesting case. It is very reminiscent about a case that happened 20 years ago during my training, and I have never since re-encountered, in which a young late teenager was playing American football, you know, where the people pile each other over each other, and sustained anterior dislocation with a complete intrusion of the femoral head through the obturator foramen that proved irreducible, even by any kinds of mechanical pulling on it. And this was an acute injury that got to care within hours of the event. And the only trick that was done to redo that is to make a cut in the anterior rami of the ring to relieve the tension stress, which then allowed for the head to be pulled out. So this is just the acute version of this injury. Sometimes you can pull the head out by doing a stress relief cut in the anterior rami to allow sufficient plasticity of the ring to pull the head out. And not that that would work in a chronic case where everything is scarred and attached, but if anyone encounters this in an acute case, that's something that worked at that time.
Thanks, Kiro. Good point. Fahmy.
It was a very interesting case, and treatment was very appropriate. Surprisingly, the patient did not have such a bad function as compared. Looking at the X-rays, his function was not that bad. He was able to walk, although he had a hand or knee gait. This is like a buttonhole deformity, so like the big cup goes into a small obturator foramen, and it's very difficult to take it out. And I think we very nicely illustrate the point that less is more in such cases. You treat the patient, you don't treat the X-rays. As we saw in the CT scan image as well, that the head was really in the obturator foramen, and it was kind of locked in. And taking it out would have been more harmful than any good. So I think it was a very wise decision to just leave the head therein, because at the end of the day, we have to treat the patient, not the X-rays.
Yeah, so it's interesting, Fahmy. The video that you saw preoperatively was the first video we took 7 months after the injury, when he first came to us for possible preservation. But at that time, you know, he was not that painful as well. That's why I was hesitant to attempt it, in addition to those other findings I discussed. And then I told him, you know, and he was convinced that wait for hip replacement as well. That's why we sent him back home, and he came back after 3 years. While he was on wait list for hip replacement, the pain also got worse, and he was quite debilitated. So it would be nice to invite also Dr. Anderson. He has a good experience in these obturator dislocations as well as posterior dislocations for his input, Kira.
Yes, absolutely. Is Dr. Anderson on the line? I would love to hear his comments if he has some.
I'm here.
Oh, wonderful. There you are. Sorry, Dwayne. Sorry I didn't see you. Please, if you have comments, we'd love to hear them.
Well, on my lecture, I think I reported 5 cases of obturator dislocations, and I agree with Sammy that, and with Fahmy, that you need to look at the clinical situation. And I think the summary of my obturator experience is, number one, if they're painless and ankylosed, then you can do an osteotomy. If they're painful, then you should either do an open reduction or a total hip replacement. And I think that you should, because of the location that they are, I think even if they're maybe a couple months out, the damage to the head is usually severe. And so unless they're painless and ankylosed, do a total hip.
Great points, Dwayne. Thank you. And just another shout out to all of the faculty for their excellent lectures. And Dwayne's lecture has been shared in the chat, talking about anterior, obturator, and posterior dislocations of the hip and your approach to them. So fantastic lecture. I learned a lot. Isaac, last comment from you before we perhaps close out the session.
Yeah, Dr. Hyler, just wanted to say thank you for 2 amazing case presentations, and definitely learned a lot from your clinical experience. This is not an injury that I've seen or had the opportunity to treat in my practice. Is there any sort of issues from compression of the obturator neurovascular bundle from the femoral head being in the obturator foramen? And did the specific patient have any issues with that, and would that have changed your surgical approach here?
So are you talking about like femoral nerve or obturator nerve?
Obturator nerve.
Yeah. So I guess, obturator nerve clinically, I don't think it is that, disabling if you have an issue, especially for male patients. The other faculty members can give a comment on that. But in this specific patient, there was no any specific concern, and even the sensation from the on the medial side was actually intact, and I don't think I have seen any major complaint or issue from the obturator nerve palsy. I don't know your experience, the other faculty.
I think it's got to be out. It just doesn't make any sense to me that they're intact. I mean, you look at the anatomy, that thing's gone. And I think I have done about 6 of these total in my career. And I think if you do an osteotomy, obviously you don't need to worry about it. And I have not had problems with total hips, although I'm not sure how many total hips I've done. I'd have to review the lecture, but I don't think that the obturator nerve is intact. It can't be.
So would you think it will be clinically significant if it is intact, if it is not intact?
I don't think so.
Great point. We're just a little over time here, so I just want to sort of move towards the closing thoughts. But I know that Sushant, you have your hand up, so I'd love to hear your final comments before we move to the closing thoughts.
Yeah, just all of you all, it's been a great from everyone. That's a way to go forward. Thank you.
Thank you. Last couple of questions here in the chat that I want to make sure we get. In which position did you make the neck cut and how? Question from Abdullah Ahmed. Sammy, any comment on that?
So we did it using anterior approach. So the patient was supine. The neck is already externally rotated. So it's basically head on. You are in front of it. So the neck cut is not that difficult.
Great, thank you. Just before we go to final comments and thoughts from the faculty, I just wanted to hand it over to Haley, who, as our moderator, may have some final teaching points and lessons learned from this really fantastic case presentation. Haley?
Yeah, great. Thanks, Karen. This was an excellent session. I just want to say thank you to all of the presenters and everyone who participated in the discussion. I think as a trainee, a lot of great teaching points to take away from this. I haven't seen really any cases to this level. So I think really I'll be happy to go back through this lecture and really go through how to think about these cases and take away some of the points that folks made about how to plan for these cases and approach them. So I think it's a really great session to kick off, the month of talking about lower extremity. The cases and the discussion just seem to get better every year. So I really appreciate everyone's time and thoughts today. Thank you so much.
Thanks, Haley. Any faculty got some final comments before we close out the presentation?
Well, thank you again for organizing a wonderful international event. I mean, this is just so valuable for everyone, particularly for us here in the United States, who frankly do not see this degree of injury at times, particularly with the delay to care. It's very educational and much appreciated.
Thanks, K-Rod.
Thank you so very much for your meeting. I'm very grateful to meet you, and I hope we meet again.
Thank you, Mahmoud. Philip, any last comments, teaching points for the audience?
No, I think it's just like everything in life. We quote unquote are the faculty, but we learn so much from incredible experiences here. And so thank you so much.
Yeah, thank you. I also learned a lot, very innovative approaches to the hip and, fixing versus fixing and replacing, or replacing, getting CTA to plan the approach, make sure that you don't bag the neurovascular structures. When you're getting a reduction, doing the neurolysis of the sciatic nerve, all really important points. Using bone graft from the iliac crest or from the femoral head itself if you are doing an arthroplasty to reinforce your repair, all excellent points. And I look forward to going back and listening to this case discussion again in the future. So we're a little over time here. Thank you all for sticking around. Those of you who have just some last closing slides I have here. Thank you to all the presenters and to the faculty. We could not put these together if it wasn't for you, and we really do thank you for your commitment to improving orthopedic trauma care in resource-limited settings for poor, underserved, disadvantaged patients. Education is a major part of that, and we really do appreciate your contribution to that mission. For all of the participants on the line still, we've shared it in the chat. You can also use your smartphone to scan this QR code. Please do complete our post-conference survey. Every single live case discussion, we have a pre-session survey for you to give feedback on our course materials and our course curriculum, and then a post-session survey for you to give feedback on the cases that were presented and the faculty who provided discussion. Everybody who completes the pre and post survey for all 4 sessions will receive a certificate of participation from the Harvard Global Orthopedics Collaborative and SONA Global. Those of you who would like to continue the conversation, we had many excellent cases that were submitted for discussion, and we only were able to talk about 5, and even that felt like we could have talked for hours about each one of these cases. If you would like to continue the conversation, please do join us on our online community. You can scan these QR codes to join our WhatsApp groups. We are constantly sharing cases, discussing these with surgeons and trainees from around the world. Lastly, I'd say that we have just launched our SONA Global Academy website. You can use this QR code to access the website, sonaglobalacademy.org. You can certainly register for this conference if you haven't already. You will get the password to access the full curriculum, which includes not only excellent lectures provided by the members of the faculty here today that are relevant to today's topic, but also fantastic resources from OTA, Osgenic, JOMI, IGOT, that really showcase the key knowledge and skills that you need as a resident and also as a surgeon to handle these very advanced cases. And we thank our partners for their contributions to that. So thank you all for joining us today. We'll leave the line a little open for a little while longer so people can scan these codes and just to say the final words and goodbye. But thank you so much for joining us today. And with that, we'll end the session. Thank you.
Thank you. Thank you so much. Bye.
Kiran, I'm doing the post-conference assessment. We're asked to do rankings from 1 to 5, but it doesn't say whether 1 is the best or the worst. So I think you're gonna get mixed results. If people think 1 is the top versus 5 is the top of the quality.
You're right. That's a mistake on our part. Yeah, 5 would be the best rating. 1 is.
That's what I thought, but some people might think the other way around, and they might rate them all as 1s, not meaning that they're bad, but they're excellent.
Yeah, exactly. Yeah, maybe someone from our Sona Global team can address that quickly before too many people erroneously fill it out. Thanks for that.
Thanks for organizing a great session.